Hello, I'm Peter Hendler, and I'm currently the Clinical Engagement Lead of the Americas for SNOMED International. I'm a retired rheumatologist from Northern California. I was in private practice in the 1980s in San Francisco, and then I was with Kaiser Permanente from 1990 until 2016. I'll be presenting the SNOMED section of this talk on CPT and SNOMED CT. I'll show how they can work together to deliver a view into healthcare costs and benefits. For procedures, studies, and interventions, there are maps between SNOMED CT and CPT and vice versa. SNOMED covers the conditions that define the subpopulations and the outcomes that are measured. CPT is used to calculate the cost of both the provider's services and all the other aspects of the interventions. We'll show a scenario illustrating the use of both terminologies simultaneously to calculate a significant cost-benefit analysis ratio that otherwise would not be possible. The AMA and SNOMED International have been collaborating for more than 5 years to develop their respective coding and terminology products. Working together, this collaboration is producing tools for clinicians, hospitals, payers, and others who analyze healthcare data globally. Over the course of the last 5 years, our two organizations have improved and integrated our products for the benefit of healthcare planners and clinicians. In August 2020, the American Medical Association and SNOMED International announced a demonstration of how current procedural terminology, which is CPT, and SNOMED CT can work together to facilitate better outcomes and enhanced resource utilization by data analysis. The AMA SNOMED International demonstration product shows the advantage of using the two terminologies together, providing a path from clinical documentation to resource utilization insights. This demonstration tool highlights how healthcare administrators can leverage both code sets to align resources to population needs in complex clinical areas. For the purpose of our conversation today, we will be using breast cancer diagnosis and screening as the clinical focus of our demonstration. These integrated terminologies guide data-driven resource utilization and predictive analytics with the goal of delivering improved patient outcomes. With global healthcare costs growing more than 8% per year, even before the pandemic, there's pressure on health systems to get the best care possible with limited resources. It's about increasing the value for health systems and improving outcomes for patients, making the healthcare resources go further. This is especially true in population health, where cost-benefit analysis is necessary. How can we learn how different approaches to patient conditions and outcomes correlate with the cost of providing care? How can health systems both optimize existing resources and predict the cost of care across patient populations? This can be accomplished by using SNOMED CT and current procedural terminology, CPT, together. SNOMED CT is the global leader in clinical terminology. It captures both the diagnosis, the outcomes, and procedures used. CPT is the leading procedural and billing terminology and captures the procedures used to treat the diagnosis and the resources required for that treatment. When used together, CPT and SNOMED CT deliver a complete view into healthcare costs. They enable you to make evidence-based decisions, avoid waste, and predict the cost of providing care to your patients. Let's take a look at how this works in practice. In the following scenario, We'll look at a care pathway for breast cancer screening. We'll take the view of a health official in government or a health system leader. In this demonstration, we'll calculate the marginal cost of detecting early stage breast cancer with more frequent screening. We'll look at annual and biannual screening. We'll start by looking at the patient population with SNOMED. This scenario will use the SNOMED and CPT demo tool to tell the story. Before we approach this demo, it's important to have a basic understanding of SNOMED CT. In SNOMED CT, all concepts, of which there are more than 350,000, are part of a hierarchy. Terms have parents, and above the parents, ancestors. They have children, and below the children, they have descendants. In this slide, we see the parents and the children of infiltrating ductal carcinoma of breast. Also, SNOMED is not merely a list of words associated with codes. It's a structure of relationships based on logic. As terminologies and code systems are both designed with different purposes in mind, this comparison will show the search results for searching for infiltrating ductal carcinoma of breast using both SNOMED CT and ICD-10. The SNOMED CT result and the term is on the bottom left of this slide. It shows a diagram of the inferred structure of the infiltrating ductal carcinoma of breast concept. It's this logical structure that defines the term. The term can be searched using not only its words, but its relationships. For example, you can say, find all terms that have finding site breast and have morphology infiltrating ductal carcinoma. This advanced kind of search is not possible in other terminologies that don't possess a formal logical structure. At the top and the right side of the slide, we see the same search presented using ICD-10. We can see that the term that we actually want is in the synonym list, but that's not what the code belongs to. The code, the official name, is the term malignant neoplasm of unspecified site of right female breast, is much less specific and is not even specific for ductal carcinoma. We can also see that there are only descriptions and words, which works well enough for billing and statistical purposes, but because of a lack of logical structure, will not work for advanced clinical analysis. In this slide, we're looking at the structure of screening mammography. It reiterates the most important distinction between SNOMED and other code systems. SNOMED is not just a list of words and codes. It's a logical structure of meaningful relationships. We can see roles here of procedure site, method, and has intent used in its formal logical definition. SNOMED CT is the only widely used clinical terminology system that has formal logical definitions, which are critical for data analysis. There are a few other systems that exist with special focuses, such as rare diseases or genetics. But SNOMED CT is the only logic-based terminology widely used in electronic health and electronic medical record systems worldwide. Now our demo. These are some screenshots of the demo tool. On this initial screen, a user would define the cohort of patients to be analyzed. In this case, they chose females between the age of 60 and 79. The user would then choose a timeline for the procedures performed. Here, we're defining two groups, one group of every 12 months and one group of every 24 months, but with a little range of plus or minus 2 months. Finally, the user adds a SNOMED concept to get started, and here we're looking in the population for anyone who received a bilateral screening mammogram. The tool immediately gives the user an idea about what this population looks like. Out of 220,000 women in this age range, 105,000 have gotten annual screens, while 55,000 have gotten biennial screens. Already we can see that about 60,000 women in this age group are either not being screened or they're being screened outside of our defined parameters. Now we're going to add more refinements. In this case, we want to track the progression of those patients in the first screen. So if they had a positive screening, they would get a unilateral diagnostic mammogram. Searching for that SNOMED term, we further can refine the population. Now you see the number of women in this population who had an annual diagnostic mammogram on the right side. But note, the scale has changed. Don't compare the visual heights of the bars, because the scale on the right goes a little above 8,000, but the scale on the left goes considerably above 60,000. But the numbers are important because we're going to use them in a later calculation. Now we're refining them even further. And note again that this scale only goes as high as 4,000. But these are the patients who've had a biopsy. From here, positive results will fall into different categories also defined by SNOMED. So these are the SNOMED defined stage comparisons. SNOMED makes it easier to sort through each stage of treatment and identify the different populations along the care pathway. We would expect to find more stage 2, which is a less treatable form of cancer, in the infrequently screened group. And in fact, that is true if you get the raw numbers and add them up. This in turn will allow us to conduct an analysis on each pathway that will identify the resources used to provide this care. And then using these subpopulations, we're prepared to take the numbers and calculate meaningful insights. In order to do this, both groups have to be normalized to the same number. We chose to normalize them to 100,000 patients. And when we do that, we found that there were 7 more patients in the less screened group that had stage 2 or greater cancer. In other words, harder to treat, more dangerous cancer. Leveraging CPT, once we know the cost of both groups and the number of patients who have the advanced cancer, it's very easy to calculate the marginal cost the cost for saving a patient from having stage 2 or greater cancer. And this is what the demo will be able to show us in the analysis that administrators will need to make allocation decisions. To better understand this, I'm pleased to hand over the reins to Laurie McGraw to share how we engage in the administrative analysis with CPT.
Thank you, Dr. Hendler. I appreciate that introduction. And as mentioned, I'm Laurie McGraw. I am the Senior Vice President of the American Medical Association with responsibility for CPT, the current procedural terminology. Let me get started by giving a little bit of background on CPT and the features of this code set that make it possible to provide the answers to the types of resource allocation questions. And then we'll go back to the breast cancer example that Dr. Hendler began. So first of all, CPT, the current procedural terminology, it is provided by the American Medical Association, and we've been providing it for over 50 years. It's about 10,000 codes, which represent all medical, surgical, radiology, laboratory, anesthesiology, and evaluation and management services. It's the standard used in the United States and several other countries for purposes of documentation, coding, and billing. This code set, it's overseen by an independent panel. And this, there are a number of public meetings that are done every year. It is an open and transparent process for advancing the code set. It's updated annually. There are some parts of the code set that are updated more frequently, like PLA codes, which are largely genomic codes, which are going at really advancing at a different pace. And then once these codes go through the CPT process, there's 17 members on this panel. There's 200 other advisors appointed to support this panel with many, many other physicians, practicing physicians who support the process. Once the codes are determined by the panel, they then move to the AMA Specialty Society RVS Update Committee, where then they are valued in terms of how much resource is needed to provide those different procedures and services. Now, many of the CPT codes show physician work and the amount and type of resources that are being used. This is one of the most powerful aspects of CPT content. Now, here's how it works. Each CPT code is linked to a procedure or service that is codified with a unique descriptor. Many of the CPT Category 1 codes, they're also linked to the expensive resources needed to perform that procedure. These resources can be expressed as units, physician work units, or practice expense units. So for example, in this example of a mammography, there's 0.76 physician units, but also 3.04 expense units. That's equipment and things of that nature. We can go into more detail on that, but the main idea here is that we have a fair, consistent way of describing the amount of resources that go into delivering care. SNOMED and CPT, the effect here is that you have an improved clarity into the resources that are used to provide that care. So let's go back to our breast cancer example just to illustrate how that's used. In this example, there's 97,000 patients with 160,000 screenings that have been performed. Now, to support these procedures, 43 physicians delivered those, and 3 mammography machines were used, all part of a $9.2 million budget. With this traditional view, it would be hard to know if your physicians and your equipment were being used efficiently because they were delivering other procedures or might have been being used for other care. Now, by using SNOMED and CPT, you have a more granular view of how many physicians and equipment resources were used to provide the breast cancer screening and the treatment for each patient population. It's worth underscoring this point. SNOMED with CPT allow you to see the type and quantity of resources used for every care pathway and population. As you might imagine, when you have improved clarity or resource usage, you have an improved ability to use them efficiently. Now let's go back to analyzing the care pathways of the breast cancer population. This chart here shows you a view of both physician and expense resources that are used at each stage of the diagnosis. Now, it's easy to see here that one of the steps, the breast cancer screening, it's consuming a lot of resources. This is a logarithmic scale on our y-axis here. Now, we could benchmark this against other hospitals in our system or region to see if we are using these resources efficiently and inefficiently. Not only that, we can use these resource units to quantify exactly how much and what kind of resources are being used inefficiently. In this scenario, we have 393,000 expense units, or the equipment here, that are being used, and we've determined that this is higher than what we want it to be. Now, once we've identified this as a problem, the next step is deciding how best to address it. Here's where SNOMED with CPT can help you with that. Now, SNOMED with CPT, We can't do the optimization analysis for you, but these terminologies do enable it. A health system leader has many options to change how resources are allocated, such as extending hours or consolidating staff or adopting new testing policies. In each case, they can use SNOMED with CPT to measure resource utilization of each of those options to determine which approach is best. Once we've optimized our current resources around the care pathways, we can use the same approach to figure out how our resource utilization will change as some care pathways increase or decrease. Put another way, because we can more easily see what kind of resources it will take to care for our patient population, we can more accurately choose the future resource investments that will be used to provide for the care. With thousands of areas to evaluate, you can extend your analytics to any procedure combination and get a detailed breakdown of where your resources are being used. This analysis works at a high level, as in this example here, where we're comparing lumpectomies and mastectomies. The analysis can also work at a very detailed level through all care path variations. For example, you could look at resources used for patients who did an annual exam in stage 1 and then a biannual exam in stage 2, or the opposite. Because SNOMED CT captures care in such a detailed way, we can use the mapping to CPT to compare very specific lines of care at different levels of detail. By extending the type of analysis to care paths throughout the healthcare system, there are significant opportunities to improve resource allocation. What you choose depends on the care your population needs. SNOMED and CPT empower you to make better decisions around the resources based on your resources and your priorities. Now, those examples, that's just one way that SNOMED with CPT can be used. Used properly, the increased clarity that these combined terminologies provide allow you to deliver better care with the same resources. And they can help you plan more effectively for the future, whether that's hiring new types of specialists, whether that's implementing new types of digital therapies or digital medicine or advanced analytics or AI. SNOMED with CPT can help you make those decisions. Ultimately, SNOMED and CPT supports improving outcomes, lowering costs, and providing better access for your patients to care. Thank you very much for the opportunity to share this example of how SNOMED with CPT can work together to support you in the decisions that you're making to deliver care to your populations. And with that, we welcome the opportunity to answer further questions. Thank you very much.
Thank you very much, Laurie and Peter, who's not here with us, but welcome to the live QA. Hopefully you can hear me, and I'm hoping that our attendees can hear us as well. You see we had one question that you've already answered. I don't know if you have anything else you want to add on that at the moment.
Good morning, and actually I'm not familiar with that particular database, but I think that you know, the use case of emergency services is one where CPT, the current procedural terminology that we were talking about with the combination of SNOMED, that would be a good use case to look at efficiency and things of that nature. So those are exactly the types of use cases that we were trying to portray with the example of breast cancer, where the combination of these two terminologies can be particularly helpful for answering those kinds of questions.
Great, thank you very much. I can open the floor to any attendees who'd like to ask a question. Please do type your questions in. But I think while we're waiting for a question, I have a question of my own. So, I mean, very interesting presentation. I'm curious to see where you see the implementations of SNOMED and CPT in your experience at the moment. I mean, how often are you coming across the joint implementations?
Well, I mean, most certainly in the United States, both terminologies are used across the entire nation, and we have a few examples of other countries who have adopted both terminologies. So I think as what we are seeing across the globe, certainly with digital health being adopted at an increasingly rapid pace to deal with, just people with chronic conditions. So these tools and these wonderful innovations are being adopted. We're going to see the need, I think, for procedural and medical services terminology set that can really work at the pace of these innovations. And so we anticipate that the need for use of CPT, which is updated at such a regular frequency and at the pace of digital medicine, will become more and more important. And so that's why we wanted to start to talk about that today at this conference.
Great, thank you very much. So we do have a question. I'll read it out. So it's from Alistair Kenworthy, New Zealand. It's a neat collaboration. Do you think CPT could become more fully integrated with SNOMED CT, such as how the nursing terminology is heading?
Good morning, Alistair. I'm so sorry that I can't see you in person at this conference today. Thank you for the question. I hope so. We have been collaborating with SNOMED for the past few years. We've really appreciated and enjoyed working with SNOMED and the SNOMED community. And our intention is absolutely to do more integration. This is a first example of a demonstration tool. We have plans underway to create a sandbox of sorts so that people can explore different use cases that may be of importance to their particular circumstance, geography, health system, whatnot, and then how the integration beyond just mapping, which is available today, could be used, is something that we will explore, and it also will be responsive to needs of the various communities or adopters as we continue to move forward.
Thank you. So on this platform, we can't have a return question from Master, so it's somewhat one way. So we have another question from John Snyder at the US National Library of Medicine. How often are the mappings from SNOMED to CPT being updated to help support this analysis?
Yeah, great question. Thank you. We had a bit of a gap in terms of the mappings, and so in time. So currently, we're updating them on an annualized basis. But I think that as as I just mentioned, with certainly digital medicine moving at a rapid pace, and we have currently we have a tremendous volume of codes which are being updated even more frequently for the pandemic. So the diagnostic testing, with vaccines coming and hopefully very soon, we will have things updated more frequently. So in terms of a timetable, the calendar annual has been the pace, but I would anticipate that we need more frequent updating, and we certainly have the resources to do that.
Excellent, thank you. We have a question from Kai Cooley at SNOMED International. How CPT could be applied in the UK? Would procedure costs need to be standardized, or could each organization need to have CPT customized?
Great question. We have today, we are working through a governance process of how CPT could be localized within each geography, if you will. We have today the ability to modify what are the physician descriptors that go alongside the codes. We have consumer descriptors, physician descriptors, along with the CPT codes. We are working through a process for that type of localization so that different areas can provide that localization, and then we bring it back up through the CPT panel process. These are discussions that are currently underway, and we're actually working with our panel to ensure that we can keep, of course, the integrity of the code set, but then also meet the specific needs of the different areas where it is intended to be used.
Great, thank you very much. I'm aware of the time now. We've hit the half hour, so I think thank you very much for everybody attending, and thank you very much, Laurie, for getting up what I assume is a little bit early to answer questions on the call. So enjoy the rest of the conference.
Yes, thank you very much. I appreciate it.
Thank you. Goodbye, everybody. Thank you.